Hello, hello, hello. Welcome everybody to the Boston Globe's Health Equity Week. Today, I'm so excited to be talking about prioritizing mental health and reducing racial inequities with Susan Wilkinson, founder of Ally Integrated Healthcare, Dr. Kevin Simon, Boston Public Health Commission's first ever Chief Behavioral Health Officer, and Dr. Charmaine Jackman, founder of InnoPsych Mental Health Resources for BIPOC people. All of you, please join me. Welcome. First, I want to kind of ground us in, what it means to even be well. Because when we talk about wellness, everyone kind of defines that differently. And when we talk about mental health, that's defined differently as well. So I'll start with you, Dr. Jackman.
Good afternoon, and it's a pleasure to be here. So as you said, we all have a personal definition of wellness. I like to use the wellness wheel, which has like 8 characteristics that include your social relationships, physical health, financial health, all those things that make up our occupation. But when I break down a definition that I use for myself and I use with clients, it's everyday practices that communicate how much you are worth, right? That communicates your worth. Because if you believe you're worthy of sleep, you're going to prioritize sleep. If you believe you're worthy of healthy relationships and communication, you're going to prioritize that. So it's really understanding the things that make you feel good and making sure you're doing things every day to practice that.
Susan?
Hi there, I'm Susan Wilkinson, Ally Integrated Healthcare. To just piggyback off of Dr. Jackman's definition, and I wholeheartedly agree with that. I think also the notion of finding your own balance, finding what really makes you tick, kind of getting to know yourself and fall in love with who you are, because we can't really quantify wellness in whatever way that we can if we don't even know what we want. What do I want for myself? So in that context of really understanding yourself, falling in love with who you are, can really facilitate everything that Dr. Jackman just talked about.
Yeah, so Dr. Simon, and one, thank you for inviting me and hosting this. So, in reference to wellness, and I generally keep a journal with me to take notes down. I think when we think about just this spectrum of health, and so I recognize that I'm a physician, psychiatrist, and so sometimes when I'm thinking about health and wellness, it sometimes is in the regards of people who are unwell. And so I think when I think about wellness, I'm not thinking about disease state or anything. Like Dr. Jackman and Susan just noted, I would say emotional, spiritual, physical, financial, occupation, and then like your environment, right? Like whether that's your actual home structure and all the other environments that I just mentioned, right? Your social environment, because if you're well financially, but then somehow your relationships with your significant other, let alone relationships with friends, is fractured. Although you're financially well, you probably actually don't feel all that great because who is it that you're sharing that with, right? Recognizing spirituality. So I grew up in the church. I'm a preacher's kid. You could be great physically, but sometimes you're wrestling with things emotionally or spiritually. So wellness is not one point in time. It's a true like continuous evolution that I think we're all on, and trying to identify how best to ensure all aspects of our life are well is what I would call it the pursuit of wellness.
I love that. It's a journey. It's an ongoing journey. and there's no like one quick fix, which, you know, leads me to bring up kind of the branding and selling of wellness.
Mhm.
And, you know, look, I love a good spa day. I love, you know, getting a massage, getting my nails done. But I think there's been this real odd advertising, marketing, business effort to sort of conflate mental health and holistic wellness with things you can buy. Can we talk a little bit about navigating that, especially in our community, where there is a strained relationship with the healthcare system, you know, and you're getting these messages of, you know, oh, self-care Sunday, just, you know, go get your hair done, go get your nails done, you'll be good. That'll, you know, dust yourself off. It's going to be fine. Go buy something. Take a vacation. Everything will be fixed.
You want to go, Dr. Jackman?
Dr. Jackman, you want to kick us off?
Yes. I love this question, and I will try not to get on a soapbox, but I really, what I talk about, I think about the external, right? So the getting your hair done, your lineup, you know, all that stuff that's external, right? And I think about that as pampering. But when we're thinking about deep wellness, deep self-care, it's really about your soul care. So that's the internal stuff. So Dr. Simon mentioned journaling, right? It might be seeing a therapist, doing yoga and practices like that. There's this amazing quote by Bell Hooks that talks about luxury or wellness. And she talks about wellness as, you know, we've been kind of almost trained or brainwashed that wellness is a white luxury. And so when we think about those things about therapy, maybe yoga, those things that really get to our soul care, we haven't prioritized that. We don't put value on it, right? We say it's too expensive, even if we may not even know how much it costs, right? And so I think how we're really in a space and a time where I see communities of color really diving into, you know, therapy and really looking to understand themselves. And so, you know, at Insight, our goal is to make sure people understand like the range of therapy approaches that are possible, because I definitely think talk therapy is not the only thing that's the only way that you can heal. But I really kind of help people shift that idea of what's external is pretty, it doesn't last, but that internal soul care actually leads to your long-term healing.
And I love that you use the word healing, because I think oftentimes we approach things in a more curative standpoint, where we do prioritize symptoms over the holistic human being. And to also add to that, I always remind people what works for you. Let's be practical. Journaling, we have so much evidence to really support that. What if you can't even write? What if you are dyslexic and that becomes a barrier itself? Can you record your journals? Find an alternative way of journaling, whatever it is. Can you make things a little bit simpler so that you can still create an avenue whereby you bring things out instead of things? Because really, what's the goal for journaling? What's the goal for all of these interventions is to make sure that you have an outlet. So I'm a huge believer in individualizing the whole plan in terms of what do you have, well, what can we work with? Let's work within that, and then stepwise. And I think overall, in terms of really authentic, deep-rooted healing, and again, to tie into the definitions that everyone gave, it's a process. And healing is not linear in terms of that. So in terms of the communities, our communities, it's just reminding people and breaking things down and making them a little bit more palatable in terms of all of these ideas that are really defeating, say, I don't have the resources to do that. I can't take a vacation. It's like, no, it doesn't have to be that. Do you enjoy going in a park? Do you enjoy hiking? And if you do, how is your health? Can you even afford to hike? Or do you have hypertension that is not even controlled? So kind of breaking it down, most of the people that I work with, I tend to work within their means and meet people at their point of need. And I think that's also one thing we can really lean into as providers in terms of helping or maybe working with our communities, kind of meeting people at their point of need overall.
Yeah, Janae, several months ago, I think I wrote a piece in the Globe that highlighted this idea of like therapeutic landscape. And so one, that is that your environment, you can try to make it therapeutic for you, right? So whether that's in Boston, you go to the Arboretum, that is a beautiful space that you can walk in for free. And we know that green spaces can be healing for individuals. It's notable that you mentioned hair. And so I'm going to plug my wife here. So my wife has sister locks. For those who don't know what sister locks are, just Google sister locks. Yet in sometimes, yes, if I go to the barber, I do feel good. I can tell you she's trying to like redo the twist. And it's a cumbersome task that I don't think she necessarily feels like enthusiastic about going through. And so sometimes we are on the couch and I'm helping her. And in that moment, we're connecting. But in the larger scheme of things, she's like, oh my, I have many more months of figuring out how to get the twist done, right? So anything that we do can be stressful or non-stressful. I think to Susan's point, in terms of thinking about how we evaluate our community and those who are BIPOC navigating the healthcare system, it's not easy by any stretch of the imagination. I, as a physician, myself have challenges sometimes navigating healthcare for my own self. So I think we should expand the conversation that we're having in reference to navigating. I saw your hand up, so I'll just pause.
Oh, you actually didn't need to pause. I think I pressed something on accident. I saw the hand and was like, I didn't mean, I mean, if anything, I was going, yes, say more. But I do want to bring in what it means. You know, all of these hurdles and ways of defining wellness and the conflation of capitalism and wellness and self-care exist for everybody. But there is a very real racial, and not just racial, like marginalized people inequities, Black folks, folks of color, immigrant people, queer people, trans folks, especially disabled people, marginalized people in this country have a very different relationship with the healthcare system and their environment. You know, all of you have talked about the wellness wheel and the environment around us and all of these things, and green spaces, which we know in Black and Brown communities, especially in a city like Boston, are lacking. You know, we don't have a lot of green spaces. You do have to travel a little further out to get to green spaces. There has been a historical mistrust of the healthcare system because we were experimented on, exploited, and used. Then there's the access issue and you know, finding, you know, once we get over the stigma of even talking about mental health and what it means to see a therapist, there's actually like finding that access to find someone that's in your network or someone you can afford that's not in your network that can meet you where you're at culturally and mentally. How does race factor into the wellness wheel and into how we engage with our mental health?
So I'll just jump in here. So you mentioned a couple of things, right? In the network, right? Which also itself is implying certain things, right? Insurance, right? Which implies 80% of Americans get their insurance from their employer, right? And so what's the economic situation for certain communities and pockets of population, right? That's going to dictate likely the healthcare insurance. And do you have your, some of them are sponsors of this, right? Do you have your 0.32 or Blue Cross Blue Shield or Anthem or something else, right? And so I think that the challenge of healthcare and navigating it is right from the conception of healthcare insurance. It was always tethered to a job. And so if unemployment is the struggle, well, your healthcare insurance, by virtue, you're going to be paying for that for yourself. And then even for those that have healthcare insurance, specifically in the mental health space, right? Navigating to your larger systems that have a plethora of providers versus finding the niche providers that cater to you that might not be a part of the larger system is challenging. And so there tends to be a dichotomy of whether I want to see Dr. Simon, Dr. Jackman, Susan, and Ali integrated. If we're all independent providers, there's going to be an economic challenge in reference to navigating towards us, particularly if that person's not insured, because of, again, 80% of individuals get their insurance vis-a-vis their employer. So capitalism is like baked in to the system.
Yeah. Yeah, I want to jump in and kind of elevate some of the conversation you're saying. So I love the idea that you're tying employment and insurance. I have gone from, and I shared this an event we were all at this week. I started out working at one of the large hospitals. So I had this great insurance plan. As I moved, changed jobs, and now I'm a full-time entrepreneur, my access to quality healthcare is impacted by the type of insurance that I have. And I'm going to put my husband here in blast because my daughter was sick earlier last week. And, I took her to the doctor because we're trying to figure out what's going on. He's like, why do you take her to the doctor? Worrying about self-care. We have this huge deductible, right? And so, I think, we have some means, but it does cause a burden. But people do make choices about, am I going to go to the doctor for this thing? Because that's going to mean I haven't met my deductible yet. I don't know what the bill is going to be, and I don't know if I'm going to afford it. And if I'm not employed, it's like, so it just adds to that load. One of the things you're also raising, so InnoPsych is really one of those specific directories, right? So if you're looking for a therapist of color, you come to us, we help you find that. But what, Dr. Simon, you're saying, like all the providers on there are in independent practice. They have their own businesses. And that means there's certain insurances they're not going to take because the reimbursement rates, what they get paid to see you, is very low. So they're making choices about which insurances they're going to take. So that leaves a lot of people without access. And we're also seeing that more and more because of the bureaucracy that's involved in billing insurance company to get paid gets more complicated. They're reimbursing less. And so people are saying, you know what, I don't want to deal with insurance. So I'm just going to do self-pay, right? So that then leaves a whole nother group of people who don't have access. So, I think there's this balance where people are trying to want to see clients that look like them and they do great work with, but also how do they maintain a healthy lifestyle? How do they, live in these very expensive places? And I think one of the things that I got humbled was because I think even in Massachusetts, we have access to great facilities and mental health is on most of our plans. That's not the case in every part of the country. So there are people who may have health insurance, but mental health is not covered, even though it's supposed to be, right? So we also want to take this national conversation because it's not the same in every state.
Thank you all for hitting the nail where it should be. The truth is, and again, my background is I've worked for major medical, big medical centers, and the most recent employer being BMC, where I really was invested in the population being treated there because one, I am an immigrant. I can relate to a lot of their struggles and everything. But I remember telling myself, I want to stay here for at least 5 years to give back and just, and by the way, I'm in the city. I'm sorry if you're hearing all of those ambulances, but to piggyback onto what you were all saying, the complexity of what it means to have health insurance. And I raised this when we were at that event. When I was an employee, I understood health insurance differently. And now that I am an employer and also a business owner, I understand health insurance differently. And I think we have this gap that's between the benefits departments when people are getting oriented, being given all of these various plans. I don't think I ever understood at all what I was signing up for. All I remember, okay, I know I need something that has a lower deductible, that has a lower copay. I'm taking this. No one ever sat down to really help me understand what you're signing up for. It's natural as human beings, we want to save money. So we end up going for the plans that usually cost less, yet in the long run, they're going to cost us more. Now, having been on this side of the aisle and understanding the reimbursement system, it's a beast, it's a machine. So then people begin, none of us, I don't know, I have a network of friends in private practice. We want to do good work. We want to really contribute positively to people's lives. We also have to remember we got bills to pay. For these little practices to go on, it's very, very expensive. Not to mention the traditional ways of the delivery of care. Who came up with the idea that a 60-minute appointment is enough for an intake? Says who? If we're going to deliver culturally congruent care, we need to go back to the drawing board and scrap that. From a cultural perspective, just even introducing each other, it takes us more than 60 minutes. So who are you to tell me building a therapeutic alliance with a person in front of me who has a complex history? If you do more than 60 minutes, we are going to audit your charts and we're not going to pay you. Then you're leaving people who are willing to do the hard work. Clinical work is hard. The emotional load that people take on, okay, that's not even to talk about the investments that people took on to be in the positions they're in to really help. And then you're telling me 60 minutes. So that's going to break up. That's why people are ending up making the choices they are making, which is actually perpetuating the difficulty in access to quality care. Trust me, I've been in these hospitals. Private practices oftentimes deliver even more personalized care than the big hospitals, because we're not seeing 20, 30 patients a day. I can sit down and go through things with my patient to troubleshoot and find solutions. By doing that, I'm having outcomes that are really desirable and keeping people out of the acute settings, but yet we get paid less. So it's a very, very difficult situation to be in. And yes, when we do turn people away, it breaks your heart, but it's not because we want to, it's because we want to deliver good care, but also being compensated appropriately. So I'm glad we are actually talking about this.
No, and you all make very important points that we all need to be reflecting upon and thinking about as we move forward to combat inequities. Can we talk a little bit about, I know I've repeatedly brought up sort of the distrust of the system and the distrust of doctors. Can we talk about how we combat that, how we kind of create dialogue around safe spaces in healthcare, safe spaces in therapy, and also just remove the stigma that exists about Black people and brown folks just going to therapy, period. I feel like I grew up just hearing like, you're all right, constantly being told I'm all right, you're all right, you're strong, you got this, like, instead of anyone actually registering like my feelings or the fact that, even as I got older and navigating journalism, the weathering that I experienced as a Black person, as a Black woman who covers identity and race and social justice, it is just like constantly being told, this isn't a real problem, you're okay. So can we, talk a little bit about what it means to create safe space and remove stigma around, folks of color seeking therapy?
Yeah, I think that has definitely been a huge mission of mine in creating InnoPsych. And I think one of the first ways is education, right? So how do you make sure our community know what therapy is, like what happens in the room? And so part of our work has been actually making therapists more visible. Let's get out of the office, right? Because we don't know what happens inside that office. And the media doesn't help, right? They, often portray therapists as it's kind of nutty people. And so that does not help the message at all. So I do a lot whenever I'm seeing new clients, I talk about really like, what is this process? What are your rights, right? So you have the right, if this doesn't work, let me know, right? If we talk and it's still not working, I want to refer you to somebody else, right? So your therapy space, you should feel comfortable. You should be able to talk about things. You should not get experience bias or racism in that space. So I think it's about, and like, how do you interview that potential therapist or provider, right? So you have the right to call and say, I want to check in with you for 10 minutes and see if we vibe, right? And so I think part of that is letting people know like they have rights, because I think, there's also this authority, this hierarchy that can exist in the therapy space. And I do a lot of work about deconstructing that. So you know your life, and you want to work with somebody who you connect with. So I think big part of that is education. One of the things that I've been working on with a colleague is the idea of, we talk about cultural competence or culturally congruent care. Now we know that therapists of color make up less than 20% of all therapists. So part of that challenge in finding a therapist of color is that there are just not enough of us. But how do we get our white colleagues to, if you are seeing a white colleague, to know, like, how do they make sure that they're practicing in a way that is culturally congruent? One of the things that we're seeing that a lot of professional associations, and actually not the association, but state licensing boards, don't require providers to have any cultural competence as part of their renewal process. So there are a number of states that have been doing that. We're working in Massachusetts to get that passed, because if we're all required to do for psychologists 20 hours every 2 years. But if none of that is required to learn more about other cultures, you could go your whole career and not ever learn anything. So I think that's one of the other ways that I will add. So educating the client, but also making sure that our providers are steeped in culturally competent care. And I know my colleagues have other things they want to add there. So I'll stop for now.
Yeah, so I would wholly agree with Dr. Jackman in reference to educating patients, educating providers. I will go off the cuff here. I'm going to share my screen. So I strive to do a bit of educating of provider systems and trying to do it in kind of nuanced ways that are somewhat interesting. So like you see this paper, This Is Us, the case examination of Black men in therapy, right? So what am I doing? I'm highlighting This Is Us, the actual film that I know, or TV show that I know a lot of people have watched. And while watching it, I'm like, oh, wait a minute. There's a way that I can translate this to colleagues of mine who don't even look like me, and what they might be able to gather from the show, such that when they do engage with a patient that is non-racially congruent with them, they know how to engage. So I strive to, in the academic realm that I'm in, I strive to weave in narratives that help explain subtle nuances in reference to differences that patients might experience. I'll plug my wife here again. She's a physician, internal medicine, and she saw a patient. The woman was younger, been in the hospital for a very long time, and again, I'm going back with hair. Her hair was like matted together, and Brittany was like, anybody want to care for her hair? And on her own, of course, she went to Walgreens or CVS, whichever one, got products that are Afrocentric, and with some of the nursing staff, some of the MAs, actually washed the woman's hair, cut some of it off, and that woman's affect or how she was experiencing being in the hospital shifted. And so that actually turned into something of a quality improvement project. It's like, oh, wait a minute, in our system, do we have large bore combs? Something I learned that certain cultures use dry shampoo. I was like, dry shampoo? I've never, purchased dry shampoo. And I'm mentioning this because there are a multitude of ways in which one can feel better about themselves, right? We're talking about wellness holistically. And so if as a system, right, hospital system, healthcare system, we don't have persons like us in certain positions, it will never be a part of the conversation, let alone at the table. And so now her hospital system is thinking, oh, wait a minute, what other type of products do we need to be purchasing? And you gotta think, this is a system that's been in existence hundreds of years. And it's, 2023, they're saying, oh, wait a minute, this is a cadre of patients that we see. What are the different items that they might need for themselves feel well, feel better, right? So I think navigating that trust factor, because when I see patients, I recognize despite what I look like, I'm a part of the system. And they're not necessarily going to be immediately trusting of Dr. Simon. And so I take my time. And to Susan's point, yeah, it's 60 minutes. And I know that I'm not going to get every single recommendation out of my mouth in that 60 minutes. But I'm like, hey, we can meet again in 2 weeks. We can meet again. And I'm building that longitudinal relationship. And hopefully they recognize, oh, you know what? Dr. Simon is not that psychiatrist that I meet the first day, is trying to prescribe my son or my daughter 10 different things. And so the families that I engage in, yeah, it's very individualized, even though I'm a part of a larger system. So those are some of the ways that I'm trying to help our larger society, let alone providers or patients, recognize that there can be trust that is built.
Absolutely, I agree with that. And also to add on to that, I think the idea of healing communities, we really need to get comfortable with that idea of healing communities, because the need is so big that one-to-one delivery of care is not serving us well. So becoming comfortable with the idea of creating healing communities, whether it's support groups that people do feel comfortable in, because evidence has also shown that the power of that shared experience goes a long way. When I sit in a group and someone talks about something they struggle with, I can relate with, and I feel validated, I feel seen, right? I build a community right there. So I think we should really get comfortable in terms of redefining what does it mean to meet our community's needs in that context. So also we have to remember that, and thank you so much, Dr. Simon, for highlighting that oftentimes we do have the choice to tell a patient and say, hey, maybe today we might not get to everything, but let's meet in 2 weeks. Well, can that person afford to take off time again in 2 weeks? Can they afford to do that? Can their job allow them to do that? Because I also work with such people who are like, no, I can't. I don't have the time. I have to work, or I have childcare, or I have this. So again, also going back to the drawing board, now we know so much about delivery of care. Unlike maybe internal medicine, where I can put your lab work and say, hey, this is where your red blood cells are. This is where I want you to be. Right? We don't have that. And yet we are supposed to rule out medical contributors to mental health. I'm a huge believer in integrated behavioral health. That's another system where a person already has a medical home. Why can't we work on refining that modality of delivering care and have mental health providers embedded in their medical homes to work alongside with their primary care doctors? Because if the person shows up to see their primary care doctor and the mental health provider is actually in the clinic, everything can be taken care of. And in terms of the burden to the patient, taking time off, using resources they already don't have, that burden goes down. But again, and this is my last point, we also have to prioritize providers' health as well. So Dr. Simon, your wife to be able to recognize that need specific to that patient, she was in a good space
Oh,
to
definitely.
be able to look and say, oh, this doesn't make sense. But we have providers who are unplugged, who are plugged out of the system. Their own mental health. I'm lucky to be in a position that probably 60% of my panel are actually providers themselves. And they are what? Families. They are really hurting. They are really in pain, right? So it's hard for someone who's in so much pain to recognize another person's need when their own needs are not being addressed. So I think also that's one thing we need to really honestly, openly talk about.
And can I, Jeanette, I know you're gonna ask a question, and this is just a policy piece, so I'm wonky on policy. The state of Massachusetts, so apologies to other states, you should follow some of what we're doing in Massachusetts. The state of Massachusetts, just January of this year, our Division of Insurance indicated that private payers, as well as our public system like Mass Health, has to and is very strongly encouraged to pay for psychiatric collaborative care, which is exactly what Susan's highlighting, the idea of embedding a provider. And honestly, even this embedding the provider, if there's a primary practice, it could be out in Worcester, it could be out in Dedham, it could be somewhere outside the Metro Boston area. And they contact me, for instance, I'm a psychiatrist, and they're telling me about the patient. And they have a case manager there, and I can give them a recommendation. Classically, that phone call, that relationship would not have been profitable for that primary care system to engage me in that kind of way. But now the Division of Insurance is saying, we want to encourage that that payment does happen. And so that is one tether or one feather of a form of collaborative care that is being paid for now, that wasn't historically paid for, even though CMS or the Center for Medicaid and Medicare could allow payment for it. But again, probably still not at the reimbursement rate that's appropriate. And then just this final capitalism issue. In no other entity and field is it that the resource that is in need and low supply required to actually cost less. Yet in mental health, somehow there's low number of providers, and yet that low number of providers, you are kind of mandating, hey, but take less. Whether you're talking about cars, computers, phones, etc., things that are in need, high demand, low supply, the economics classically, they inverse, right? I just wanted to highlight that because Susan made a great point about collaborative care.
Think.
Oh, no,
One quick point. I think the other thing, just to highlight what Susan said about integrative care, where the mental professional is in the same office and suite with the physical provider, is that because I think when you come into an office and you know it's for mental health, you're looking around like who else is in there? Is somebody going to know my business? Somebody going to know why I'm here? And so having the mental provider embedded in your primary care is a great way to reduce that stigma. So I wanted to just address another issue. As you talked about, how do we decrease that stigma and make it safe for people to come in? Making that integrated, I think, is really key, because then people don't worry about who's going to see me going to the therapist's office.
No, I mean, everything all of you said is really important and imperative. I hope people who have the power to help shift these things are listening, and that we all continue to do the work. Something we talked a little bit about was community, and it made me think of Bell Hooks. I know Dr. Jackman brought her up earlier, and Bell Hooks says, like, rarely, if ever, are any of us healed in isolation. Healing is an act of communion. And, we're all suffering just from loneliness right now. It's in all the latest news stories around mental health all have to do with being lonely and feeling isolated. And it's not just we were isolated during the early chapters of the pandemic. I think a lot of us, I don't know if it's internet culture or just where we are in American life, but I feel like you can be in a party, you could see the person on, Instagram traveling all the time, and they can still really be lonely and sad. And I think this is true a lot for people of color. I look at some of the high profile cases where we've seen deaths by suicide, and it's people who I think the community generally think, oh, they're so joyful, they have all these things. And there's a real struggling happening. I created a beautiful resistance to kind of create this corrective of storytelling around people of color and create this space for joy. But I very truthfully created it at a time when I was like desperate myself for joy. And I was like very sad and very lonely and very at the bottom of the bucket of like dealing with racist trolls threatening my life. And I needed some sort of work that would help create space for our community and also space for me. And I say this as a person who has health insurance and a job and is not, suffering from poverty, but I am suffering from like loneliness and racism and weathering, and navigating the healthcare system is not easy, no matter how much money you make. It just isn't. Like putting together a care team has been one of the hardest acts of my life. Can we talk just about loneliness, talking about it, what it's doing to our communities right now, and kind of the illusion or facade of okayness when we're actually not okay?
So one, thank you for disclosing your own kind of personal journey and trying to create a personal care team, in part because one of the questions you asked earlier is how do we help destigmatize, right, behavioral health? And the reality, it's actually these types of conversations where people see people that look like them talking about this topic and hearing that, oh, wait a minute, Dr. Simon, yes, Dr. Simon even goes to somebody every Tuesday at 6 o'clock. Yeah. So it is helping to destigmatize, because that actually is the biggest hindrance towards this pursuit of the conversation, pursuit of typing in InnoPsych and let me actually find the provider. I think the other thing that you mentioned, this idea of joy, and what joy is, right? So it's actually very required for living, like this idea of creativity, harmony, space, abundance. We have to be able to feel those things. And unfortunately, for a lot of communities, the day in and day out, they don't feel energized. They don't feel abundance of freedom to go about and be in their environment, right? Their environment itself might be unsafe. And so I know, sometimes the plans that we have, and so I'm putting my city hat on here, the plans that we describe about, you know, more greenerage in the city, bike lanes in the city. When I go in community, I wholly express the things that I'm going to tell you that we're doing over the next 3-5 years are factually true. We're going to do that. Yet simultaneously, I know that may not help you today. And I think a lot of times we conflate the ideas of what we're going to do with, oh, today it's helpful. It's actually, well, no. Today you're struggling with the challenges of today. And I want to be here to create a space for you to talk about that. And together we can walk through what that looks like, and doing it with someone is generally easier than doing it by yourself. And so that's what I try to highlight, the therapeutic relationship can be, because sometimes parents or the patient themselves are like, well, what's going to happen? I said, interesting enough, I can't tell you when you're going to feel this sense of betterness. However, if we're doing this the right way, there will be a time where you're like, oh, I want to come back and talk more. And I see it time and time again. And then for even those that say, oh, I'm good now, say, okay, yeah, I get it, you're good. Months later, if they've detached from the service, right, they say, oh, wait, hey, can we have a check-in again? So I think this idea of how is it that we create community space such that people aren't feeling lonely. That is the challenge. And it's where, this is where I call like low hanging fruit solutions exist, right? So your poetry jam, your theater in the park or music in the park. If it is actual therapy, I think psychoeducational groups is very helpful. I've done that when I used to be at the VA, have a whole host of veterans talking about trauma. Not that any one of them needs to talk about it, but they can recognize, oh, wait a minute, I'm not by myself. And so I think that we definitely can do that in our communities. And that's what some of the things that we're striving to do, such that it, if the three of us, for example, said, oh, we're going to do groups of 10 for 6 to 8 weeks. You do that 4 times over, you actually have 100 sets of people that you've been able to treat, or at least provide some very targeted information that's very different than them on their own trying to navigate this maze that we call the mental health system. So I think there are avenues for community healing in a way that we haven't really tapped into as a community in a long time.
I love this question. I actually just did a workshop a couple of days ago about Black joy and resistance. And I included healing, right? And I actually referenced a beautiful resistance because I think it's so powerful. And this idea, there's a quote from Bettina Love, who wrote a book called We Need to Do More Than Survive. It's about education. She talks about we can't have liberation without joy. Maya Angelou has talked about in the struggle lies the joy. And so as we think about, I think, what I hear you're asking, Janae, is like, we're in these environments, whether it's work, whether it's just in community, where our identity just showing up in some space is causing some reaction to someone. It's, leading to violence, leading to death. And how do we navigate that in this backdrop of loneliness that existed before the pandemic, but definitely increased? The US Surgeon General just recently put out a report comparing premature death due to loneliness as equal to smoking 15 cigarettes a day. So, so it's really another mental health issue, a public health crisis. So how do we find joy if we don't feel joyful? As you mentioned, we look at people's social media feeds and we see all the beautiful things that they're sharing. We're not seeing the hurt that they may be experiencing when they turn that camera off. And I'm really, one of the things that I find really helpful as on my own journey, right, to be more social, to raise kids who are social as an introvert, is that there are these small daily things that we can do. I invite people to think back to a time, maybe back in childhood, when you just felt at peace. I talk about learning how to roller skate and then learning how to roller skate backwards, right? So that remembering of joyful times, thinking about when you're in family or in community, what are the things that just make you smile, right? What are the things that make you laugh? And so finding daily, and as I talked about when we started, this conversation about what is wellness, right? It is those everyday practices, right? Because you have to kind of practice joy, particularly in the world where there are all these financial crises and mental health crises. There are all these things that can weigh us down. But we have to kind of take a step back and really, I always touch my heart because I think that's where my joy kind of sits in my body, right? So how do we cultivate joy on a daily basis, right? It may not be these big moments where we're with big family or we're bending over laughing, right? But it might be just these little moments that bring a smile, maybe looking outside, take a short walk in your neighborhood. But I think cultivating that joy is crucial. And it is crucial for maintenance of your mental health and well-being. Because if you don't, as you shared, Janae, and I appreciate you sharing that and communicating that, because if we don't share those moments, it can be really easy to fall in the space where we need more support to get back on our feet.
Absolutely. And Janae, thank you so much for using your platform to really highlight such difficult conversations. I'm actually very happy that you mentioned the S word, the suicide, because I think wishing it away doesn't mean that it's not happening. And I'm glad that you've also highlighted, given some kind of context, how we might think people are doing well when in reality they are suffering. And we've seen so many examples lately. So 2 weeks ago, I wrote something on LinkedIn about a young doctor. She was an anesthesiologist in training at Montefiore Health Systems, very, very promising life. And she died by suicide. And none of her friends could have, everyone says, we didn't know. There is no way we could have seen this. And by the way, a big shout out to Dr. Bradley at the VA, the one person who single-handedly helped me understand why assessment of suicidality really can save lives. And it's a very uncomfortable, it's a very uncomfortable subject. I mean, you're talking to an African chick. We don't even talk about dead people if they're not yours. Later on, talk about suicide, and it's like, no, we're not gonna talk about that. We're gonna dance around it. But having spent time in the VA as well, I really learned the value of assessing for suicidality in a very, very practical way, the risk factors and all of that. And when I wrote this piece, I was just upset. I was like, this girl, I don't know her, and my heart aches and I'm crying. And this is a life, like all of her investments, her family, everyone, and I was just upset, and it hit a nerve. So many people reached out. In other words, this is something we struggle with. So to my point, I said, well, when we were having strokes everywhere, we came up with practical ideas, educating society what it means to see a droopy face. What should you do when you see a droopy face? Maybe that person is not even aware that they do have an asymmetrical face. They are really beginning to have a stroke. Now, children can recognize that and call 911. We do not ask the person having a stroke to call for themselves, okay? Because we've taken the time to educate the community. And there are modifiable factors related to strokes. And sometimes, yes, people can feel the tingling and they can call for themselves, but oftentimes it's really the people around them who notice this and they call for this person. Yet we continue to ask people who are in distress and psychogenic pain, come out, call for pain, 988, reach out. No, let's be practical. Because if they could, they would. And no, the fallacy that everyone who really dies by suicide has not sought mental health treatment, that's not true. People can still be in treatment and still have psychogenic pain that they just want to stop. How they do that, we have no control over. But if we can engage the community and talk about these things, bring the whole topic to our kitchen tables. What are the risk factors? What are the things that you should look out for? How do you see through the facade of I'm doing well? And how do you get comfortable to ask those uncomfortable questions? How do you give people permission and say, hey, I want you, even if I say I'm doing well, I want you to probe and prod. Because I can tell you that we will save a lot of lives if we bring these skills out to the community. Now, I'm not saying we should expect the community, untrained professionals, to bear the burden of assessing for suicidality. I'm not saying that. But we can equip people with practical ways of how to just even say, hey, I know you're saying you're doing well. I don't know, but I'm here and I'm going to keep checking in. So please bear with me as I'm being annoying. You see what I'm trying to say? And maybe perhaps someone can then open up and say, you know what, you're right. When I'm assessing for suicidality, I asked people and I said, do you have someone that you absolutely give permission to say, hey, I'm coming over. I don't care what you're saying. I'm coming over and I'm staying with you. In acute care settings, we actually put people on one-to-ones. Even if they walked into the emergency room and they say, I'm suicidal, but then they change, when we bring them to the wards, we have a one-to-one sit across.
So Susan,
Susan, oh,
no, I'm acknowledging time, and
yeah.
Oh, sorry.
Janae was probably like, wait, I feel uncomfortable.
Yeah, we're about to close. But before we close, I want to, really ground us in what it means to beautifully resist. So if each of you could just briefly share what makes your life a beautiful resistance. Dr. Jackman.
So my life is a beautiful resistance because I have been called on this earth to provide healing and to communicate healing to my community. And I absolutely feel like I'm walking in my purpose. So that's why my life is a beautiful resistance.
I'm yielding to Susan.
Oh, okay. Sorry. I get very, very passionate about that one, and we will continue talking. But my life is a beautiful resistance because I've intentionally learned to cultivate space where space is not provided for me. And that has changed my life in so many ways.
And I would say that my life and work is a beautiful resistance because of these three folks. These my wife and kids, and they're really why I do the work that I do, and wanting to impact families and communities. So they're my resistance.
I just want to thank you all for the work you do, for the joy you share, for the space you make, and the healing you provide. To everybody tuned in, I'm sorry that we did not have time to get to all of the questions, but these conversations will continue in the community. This is not just for this week. This is ongoing efforts. Thank you all, and let's fight these inequities, but also remember to be caring for ourselves and each other.
Thank you for having this conversation.
Thank you for having us.
Same here. Thank you.
Thank you.